Something that is very close to my heart, and as you know, I'm a very big believer in managing heart failure patients through the spectrum of hemodynamic. And when we do that, we are very aggressively, our program, and as you can see, my partner here in University of Chicago, Gabriel Sayer and Jean Kim, that we did all this work together, we believe that we need to do hemodynamic to assess patient status in order to manage them. And we came across the ReDS technology. We said, what does it really mean to us? And I think before I'm actually starting, Bill, one of the slides that you put, and Phil Adamson, that is actually sitting in the audience, did this slide saying to us, you're not comparing same thing. You're comparing orange and apples. Hemodynamic is different than fluid. So before I'm starting my talk, I want us to just remember that. So let's see where we are. And just remember that the ReDS, as we said, it's a remote dielectric system technology to get us and to tell us what is actually the fluid content. This is one thing. What we know and what we already manage in our patient hemodynamic. So we had a very, very clear target. We have a target to investigate the relationship between the ReDS, that is fluid, and the invasive measurement of pulmonary capillary wedge pressure in the heart failure cohort in the cath lab. So this is actually a very, very simple assessment that is going back to the basic of who we are as a heart failure physician that take care of hemodynamic, but what we are trying to achieve is reducing or optimize the patient fluid status. So we took a group of patients, actually 139 heart failure patients, all comer, whoever come, and the physician decide that they want to evaluate them with hemodynamic assessment using a right heart cath in the cath lab, an assessment that will include all the traditional cath lab from CVP, RV pressure, PA pressure, pulmonary capillary wedge pressure, cardiac output and index, both in thick and thermal dilution, and of course all the elements that we can calculate from them, SVR, PVR, PAPI, etc. At the same time, exactly at the same time, while the patient wear the vest, actually in the cath lab, we assess the ReDS. So this is a simultaneous assessment. We had 139 patients, as I said, all comer. There was 55 years of age. The average BMI is 28. I'm from Chicago, so we are a little bit on the heavy side. 72% were male, 57% were Caucasian. And as you can see, this is a mixed group. Part of them were HFpEF, part of them was HFrEF. So we have an average LVEDD of 5.3, average EF of 45%, while 36% were diabetes, 27% AFib, history of ventricular arrhythmia 25%, and COPD in 6%. So this is a classical all-comer heart failure population that you will see. And then we simultaneously assess what is actually the wedge pressure that we see. And as you can see, let's take the right side here. This is the pulmonary capillary wedge pressure, and each bar represents the amount of patient. We had all variety. We had patients that are very fluid overload according to the wedge pressure or high filling pressure, with a wedge going all the way to 40. We have a bunch of patients in the range between 20 and 10. And we have even very patients that are on the dry side with a filling pressure that is coming close to 0, very dry. On the other hand, we have a very similar column here with the ReDS. To remind you, as Dr. Abraham mentioned, 35 represent the cutoff between someone that have a fluid overload above it. We have patients that have a ReDS all the way up to 60, side by side with patients that have ReDS in the 15. So very similar distribution. So now let's try to think about this distribution in a 2x2 curve. We assume that a patient will feel symptomatic with elevated filling pressure if his pulmonary capillary wedge pressure is above 18. We know that overall, of course, this is a rest situation, and some people will say 15 to 18, but overall, most of the heart failure study look at a pulmonary capillary wedge of above 18 as a cutoff. As you can see here, we have a lot of patients with pulmonary capillary wedge pressure below 18, and also a ReDS below 35. At the same time, we have a lot of patients with pulmonary capillary wedge patient above 18, meaning elevated filling pressure, and also the ReDS pressure was elevated. We're going to see that there is a minority of patients that have some elevation of wedge pressure while the ReDS was low, really minority, and some patients that the ReDS was high while the filling pressure is still not elevated. This is going on to the point that actually Dr. Abraham mentioned, that actually the volume is building the pressure, and you can see volume coming up before pressure, and there is beautiful work in it coming up from Yale, from Dr. Jeff Tostani, that demonstrate that if you put a volume into a lung, it takes time until you see the pressure coming up. So now let's understand what is the prediction value as assessing, even though we understand this is apple and oranges, elevated wedge pressure. And as you can see here, if we assume a ReDS above 34, meaning 35 or above, will tell me that this patient is elevated filling pressure. We have an AUC of 0.848, 0.85, very high AUC, giving us a sensitivity of 90%, a specificity of 77%. But more important, when we're speaking about point of care, that soon my colleague here is going to discuss, it gives us a negative predictive value of 95%. Meaning if I have a ReDS that is below 35, I in 95% of the case can say this patient also doesn't have an elevated filling pressure in the pulmonary capillary wedge pressure. So let's try to understand a little bit better. And what we like to do in the advanced heart failure group in the University of Chicago, we like to look at patients both in regard to CVP and wedge, and this is something that we started together with Dr. Berekoff many years ago. And we look at CVP below 12 and a wedge below 18, and we said those are the patients where we want to hold our heart failure patient. We have a lot of them, and their ReDS were low, as you can see here. We have patients that have actually RV failure only. CVP that's elevated, the wedge was not. Their wedge was low. But let's look at those two groups that have or elevated wedge pressure with normal CVP. Their ReDS was already high. We can capture those. And let's look at this group 4. This is the scary group that have biventricular failure, both elevation of the CVP and the pulmonary capillary wedge pressure. Their ReDS was high. So to summarize, lung fluid content as measured by ReDS correlates well with the pulmonary capillary wedge pressure. The high sensitivity and specificity, and especially the high negative predictive value, creates a reliable non-invasive tool at the point of care to rule out elevated wedge pressure in a heart failure patient and to help with heart failure medical management. I have to say that I was a little bit bummed coming here tonight because this paper is coming out in the Journal of American Heart Association, and I was planning to have a bunch of those journals waiting for you outside, just that you can see, because there is so much more detail and there is only 10 minutes to talk. But I'm sure that you can get to it online, and because we still didn't get the galley, but it's going to be in the Journal of American Heart Association. I want to take advantage and to thank Dr. Gabriel, Sarah, and Jean Kim that did the study together, and we all did overall more than 200, I think, already patient with the ReDS. So thank you very, very much.